45-year-old gentleman, sir, who presented to emergency in the month of January 2023 with signs and symptoms of obstruction. We are taken in for emergency laparotomy, sir. During the surgery, we found that his abdomen was frozen with only pus pocket collection in the pelvic region. So we had given a wash, thorough peritoneal lavage, and placed drain. We had kept the patient on follow-up. We got an imaging done. In the imaging, it suggested that there is a mass in the near the term arising from terminal ileum. Initially, it was 18 to 10 centimeter in size. Cystic soil component was present with extension into the IC junction, sir. They had given a query of probably a lymphoma or a gastrointestinal stromal tumor. Follow-up, we had sent a biopsy as well, which turned out to be positive for CD117 and DOG1, sir, which was more conclusive of a gastrointestinal stromal tumor. We have kept the patient on follow-up. Now, sir, repeat imaging has been done in the said that the size has increased, sir. It has increased in size, sir.
Where is it located?
Sir, here, terminal. This is the...
Let's talk surgery only. There is no medical oncology. It is a surgical disease.
Yes, sir.
The plan is to make a diagnosis first.
Yes, sir.
So, how do you make a diagnosis? How do they say gist? How are they saying gist?
Based on biopsy
Biopsy.
reports.
How was the biopsy done?
Sir, it was
During surgery. So, what does gist stand for?
gastrointestinal stromal tumor.
What do you mean by that?
Sir, from the it's a stromal the tissue tumor arises from the stroma.
After that, have you heard of this disease? Gastrointestinal stromal tumor. Shreya, what is it?
Rises from the stromal tissues.
So it arises from the walls, not from the lumen. So it may not produce any obstruction for a long time, but it continues to grow outwards. Very rarely produces lymph node metastasis. Very rarely causes symptoms until it is very large. Naturally, because it's not intraluminal, it's in the wall. So it tends to grow outwards. So it's usually felt as a lump, except when it is ruptured and or when it has got adhered to something else. Like in this case, when they found a frozen abdomen, maybe it had perforated, caused peritonitis, or things have got all mucked up together, so they could not find any plane. So it is safer to cause no harm and come out, because in dissection, maybe in emergency, they could have produced more damage. Okay, so we establish a diagnosis by doing core-renal biopsy, which is image guided, or during surgery if you can get a biopsy. So it was done during surgery, we got the biopsy, and now it has come out to be terminal ileum gastrointestinal stromal tumor. We don't need to keep anybody in the loop. There is no loop required. The treatment is surgery with wide local excision, margin of 3 to 4 centimeters either side. There is usually no lymph nodes, so you don't need to do lymph node dissection. So we'll plan for resection and end-to-end anastomosis. That is the management.
So can it infiltrate into the surrounding bowel loops?
It can infiltrate into the surrounding bowel loops. It can also bleed sometimes, and it can infiltrate into the mucosa also. It can produce intraluminal symptoms, but that is later.
And the malignant gist.
And the malignant gist. Right? So that would be the plan in this case. You can actually see that the bowel doesn't have the features of intestinal obstruction to the degree it should have with that size, that size too.
Yes, sir.
Okay. And what's the drug of choice for gist?
Imatinib.
Imatinib.
800 mg.
800 mg.
Every day, sir, for 3 months we give it and then we assess the response.
Actually, we don't know for how long to give.
Yes, sir.
So it's very easy to start, but very difficult to stop. Patient continues to take it until the point where toxicity develops. So that is what it amounts to, lifelong imatinib. It can be given initially, you can achieve some response and go for surgery, but it's not a resectability.
Yes,
Sir,
लंबा सांस लेना मुंह करके. Always examine the normal side everywhere. Exclude any tender spot. लंबा सांस लेते रहो. लंबा सांस. लंबा सांस. Then you come to the right side. and there is a lump here, classical lump. Lamba Saans. The lump is located here. Can you mark it? And that's a midclavicular line. Tip of the 9 cartilage, transpyloric, highest point of the iliac crest, transtubercular. Right hypochondrium. See how little is it? So a lump cannot be lying in this region for long. The moment it grows, it gets into the lumbar region. And this is the iliac region. This is the umbilical. Hypogastrium, epigastrium. Epi, hypo. Epi above, hypo below. Left hypochondrium. The lump is therefore lying in the umbilical and left
lumbar region.
and the right lumbar region.
Right.
I can get above the lump. Lamba Saans. But it is moving on respiration.
Intraperitoneal.
So it is intraperitoneal and it is mobile intraperitoneal. Bring your hand. Put your hand gently here without doing anything. Do nothing. Lamba Saans. थोड़ी देर concentrate करो. Bring your mind here. It will reveal itself. You don't have to press. The moment you press, the sensation of the hand, fingers is gone. Lamba Saans. Can you feel something?
Yes, sir.
But to examine the right iliac first, you start from liver, you start from here. And each time that he inspires, you don't put the finger in. Now during expiration. So that during inspiration you can be hit. Is it touching?
Yes, sir.
So that's where your limit is. Important now. Push it. Lamba Saans. You can get above it. So it is below you. So it's not liver. Certainly not because it's lying below also. And it is moving on respiration. You can inspect and also leave your finger there. You'll see that it's sliding in. Not frantically, but moving a little bit.
Yes, sir.
Okay?
Yes, sir.
And its consistency, can you tell me? Feel, just put your finger. Firm.
Sir, from
Mobile.
Sir, yes, mobile.
Mobile. And moving sluggish your respiration.
Yes, sir.
So, how do you differentiate an intraperitoneal lump from a retroperitoneal lump? Don't confuse it like all of you do. Parietal and intra-abdominal. Parietal means in the parietal means wall. Intra-abdominal means inside. They're different. For that we do the head raising test or leg raising test or do all cell work. The purpose is to make the abdominal muscles taut. So if it is lying under the muscles, it will disappear. If it is lying over the muscles, it will become more prominent. Clear?
Yes, sir.
Once you differentiated between parietal and intra-abdominal lump, now intra-abdominal lump can be intraperitoneal or retroperitoneal. Clear?
Yes.
Intraperitoneal lump is usually mobile, can move on respiration if it is close to the diaphragm, attached to diaphragm, or attached to an organ which is attached to diaphragm, so it will move. Huh?
Yes, sir.
Then do not do knee elbow test, it's no longer done because it is very cruel to the patient. Be kind, compassionate and considerate for the patient's discomfort. So we don't put the patient in knee elbow position. If you really want to do this test and if any friend of yours is asking, no, ये तो बताया गया किताब में, तो उसको बोलो demonstrate करो पहले. So when you ask the patient to do it, before that demonstrate the patient to how to lie in knee elbow position yourself. Which means he has to climb onto the table and demonstrate being in the knee position. He would not like it. When you don't like it, how can the patient like it? Plus it doesn't give you any information. What do you do instead of that today? Here's this test. See, I mark the medial border and then I'll ask the patient to turn. Karvat le lo, Babaji. Shabash. Now feel the lump. Put your hand. It has gone beyond. It has shifted.
Yes, sir.
So I marked it here and I'll mark it where I have reached after shift. See there it is. And now it comes back same place. This is called shift test. It originally was used in gynae for differentiating between pain in the right iliac fossa due to appendicitis or the uterine pathology. If they have problems during third trimester, it may be difficult to make a diagnosis of appendicitis. Why is it difficult to make a diagnosis of appendicitis in a pregnant abdomen?
It's an appendix gets shipped to the.
So first because the uterus has enlarged, so the
It will push the appendix come
upwards.
Secondly, it's a dangerous situation because momentum cannot reach the appendix. So appendicitis can perforate commonly. So this is a very dicey thing in pregnancy not to be able to make a diagnosis. It's very difficult. So what do?
Shift
You
test.
can do the shift test. Tenderness, feel the tenderness, mark it. Tilt the patient, feel the tenderness. If it is moved,
Uterine.
it's not appendicitis. Appendix does not move. Clear?
Yes, sir.
I have extrapolated that into this test. It is given in not given in any book, but I have found it as a replacement. In my book you find it, which is an e-textbook which came out some years ago. That is clinically a very useful test. So a lot of people follow it now all across. So palpate the lump, feel the border, tilt the patient, feel the border again. If it is moved, the lump is moving. If the lump is moving, you don't need knee elbow test. It is cruel to the patient and it's obsolete. Don't use it. So moving on, respiration, mobile and moves on tilting, shift test. Goes in favor of intraperitoneal. So I have a patient with an intraperitoneal lump. अब इसको ये define मत करना. It's an abdominal lump which is intraperitoneal. Intraperitoneal होगा ही.
If it abdomen.
Similar, like you don't say, suppose he is from Karnataka, you do not say he is from India and also from Karnataka, which is the same thing.
Yes.
Huh? But once he is an Indian, parietal part rolled out, he is intra-abdominal, intra-Indian. Now to test whether it's in Karnataka or other, you use those spinal tests. Clear?
Yes,
Yeah?
sir.
Because to begin with or to otherwise our identity is Indian. That's what we look at. So intraperitoneal lump here, and it can have a differential diagnosis. All the lumps that lie, all the organs that lie can here be considered. ढीला छोड़ दो, रोक के बैठे तुमसे साथ. Okay, ठीक. So that's a smooth surface, hard consistency, mobile, non-tender, moving on respiration. Now you don't say reducible, compressible, you already call it form. Form to hard in consistency, in fact, it's in fact on the harder side. It's hard. Feel it? Right?
Yes.
Hard compare कैसे करेंगे? Tendon, firm. Bone, hard. मसल देखो फील करो, ये रही मसल, ये फर्म है, ये हार्ड है, ये इससे मैच कर रहा है. Hard in consistency suggests malignancy. Mobile. Now the mobile, if it was, what all lies here? Ascending colon, transverse colon, descending colon, sigmoid colon, and नीचे rectum. It's almost in the central compartment. Almost. Yeah, na? Not lumbar. More likely to be from the small bowel. Small bowel, more likely. Mobile goes in favor of small bowel. Ascending colon won't be mobile. It will not move. Side to side it can, but it's not an intraperitoneal. Ascending colon is part of it is retroperitoneal. And then it will be extending for bimanual palpation here. Right? Anything if I push can be moved up like this. Right? But that doesn't qualify as intraperitoneal. Is that clear?
Yes, sir.
Therefore, my impression is a malignant intraperitoneal lump in the region where the small bowel should be. If such a large lump was inside the lumen,
Obstruction.
how big is the bowel? This big. The lump is bigger than that. Patient will have acute intestinal obstruction. He doesn't have it. So that rules out it being intraluminal. Possibility therefore is extraluminal. The differential diagnosis from the wall. Gist becomes automatically a clinical diagnosis. There is no hepatomegaly. Let's complete it. Lamba saans. See, I'm doing what I taught you, but I'm going above it. And I can insinuate my fingers under the costal margin. There is no liver, there is no spleen, and there is no free fluid. How do I look for it? Free. I'll start from the
Midline.
midline epigastrium, the Xiphi sternum. I'll keep on percussing, and don't do the mistake that people do stopping here. Go on, right down to exclude a midline lump or a full bladder or a uterus in women. I found the most resonant part was here or here. So it gives me a reference point. And now I don't come this side because there is a lump here. And don't cross too far, you will be fat here. It's all resonant. On this side, dull on percussion. Resonant. This is a dull lump. No hepatomegaly, no free fluid. Clinical impression just approach. Investigations to confirm the diagnosis, to support the diagnosis to stage the disease, to treat the patient. The investigation to confirm ultrasound first we have done. That itself can give you a lot of information. Guided core biopsy. If you find it suggests an ultrasound. Contrast enhanced CT scan to see the vascularity,
Extend.
the TNM I told you. History of T, history of N, history for M. Examine for T, for N, for M. Investigate for T, N for M, and for surgery for T and M. And the surgery would be wide local excision. If it is small bowel terminal ileum, I have no choice but to do right ankylectomy. Which is what we do. Clear? Any questions?
Awesome.
And the drug of choice is?
Imagine.
Repeat.
Imagine.
Dose?
800 mg.
800 mg.
We don't know for how long.